Platinum ERCC1 in the IALT adjuvant trial significantly prolonged survival in patients who had ERCC1 negative tumors compared to ERCC1 positive. The positives were resistant to the platinum because their enabled repair technique reversed the impact of the DNA damaging agent. It's also interesting that some lung tumors and other cancers treated with platinums that have BRCA1 somatic or sporadic upregulation or overexpression are also resistant because that's another member of the DNA repair family. So ERCC1 is fairly popular in some places. It's questionable whether it can be done only by IHC. The first major study that led to the New England Journal article was an IHC study, retrospective, Scandinavian performed, not mRNA-based. But there are also genotyping for ERCC1, which shows polymorphisms in ERCC1 can predict platinum resistance as well. And some of these have been blood-based studies, meaning germline polymorphisms in ERCC1 can have some promise, which would be an easy way to do the test. You don't have to get tumor tissue and stain it or do RT-PCR. You just get a blood sample and genotype it. So I believe that ERCC1 testing is likely to be continuously evaluated, and I believe likely to be validated as useful in trying to personalize and customize the chemotherapy for the platinum-sensitive cancers, which would include lung, colon, and of course possibly ovary and testis. For GemSAR, the marker is RRM1. Jerry Bepler and the group at the Moffitt Cancer Center particularly involved in developing this. It's again a retrospective. It's supposedly been associated with resistance to both platinum and gemcitabine. It's not been validated in a large prospective trial as well. The data is not as robust as for ERCC1, but there's some promise that this marker, which can also be done by either RT-PCR or by IHC, could guide whether GemSAR should be a frontline or a second line or used at all in lung cancer, and whether or not it would also apply to pancreatic cancer, I'm not sure. And finally, in the lung, we got to make sure we're not having a squamous cancer, given the contraindication with the risk of hemorrhage. For me, this has always been an architecture, not a histology issue. Squamous cell cancers are more often cystic lung cancers than adenocarcinomas or small cells are. And it's the cystic squamous cells that seem to have that weakened blood vessels that on the increased pressure associated with the bevacizumab can rupture and hemorrhage into the tumor cavity and then up through the bronchus and can be exsanguinating. And that was why I think it was 6 patients died of hemorrhage in the major phase 3 lung trial with Avastin. And I think they were all squamous cell cancers. So the final FDA approval said not for squamous cell. So as a pathologist, I have to make sure, especially on a small original biopsy, maybe in an inoperable patient, that it's not squamous. This isn't always as easy on H&E as you'd think. You don't get a lot of tumor, it's discohesive, you're not certain, you don't see keratinization. So we go to additional markers, and the ones that are the key ones are the P63 basal cell marker, positive in squamous, and the TTF1, the thyroid transcription factor, negative in squamous but positive in adeno. And we combine those two and sometimes some cytokeratins as well to make certain that we are classifying accurately the non-small cell cancer. We didn't have to do that until this bevacizumab issue came up. And now, again, it's important for pathology to give the accurate diagnosis that it's non-squamous so that a patient doesn't go on a bevacizumab and possibly get a hemorrhage, a complication, which would not be good since it's not indicated for currently by its FDA approval for squamous lung cancer. I had a couple of slides on, didn't want to leave the great drug imatinib out of the talk, and here's my one slide for CML. We have some superb hematopathologists in the audience who might not want to comment on my quality of my FISH test here, but we got a summation, BCR-ABL fusion gene here in a translocated CML, which received, this was one of the first patients in our institution ever to get imatinib, and she achieved both a cytogenetic as well as a morphologic remission on the drug. And that's a wonderful, again, I mentioned, you can do any type of BCR-ABL test that you've standardized in your lab for eligibility for treatment with Gleevec spec in CML. Does not have to be FISH, it could be PCR, whatever is the standard. But here comes one I find much more controversial, and that's the gastrointestinal stromal tumor. These an increasing number of these cases, seem to diagnose more and more of them every year. And the question becomes, are they or are they not imatinib sensitive? Now, we use markers and pathology in the beginning to decide whether or not they're high risk or low risk. And if they have high risk morphology, which includes a large tumor size and a high mitotic count, we may use Ki-67 labeling. If they have necrosis and certain histologic patterns, the patients may be eligible for adjuvant treatment. But we know that even in the metastatic setting, not all GISTs respond to Gleevec. And the question becomes, what's the best way to tell if a GIST is Gleevec resistant? One way is to give a dose of the drug and do FDG PET. If you don't change the glucose metabolism with one dose, it's likely a resistant GIST and the Gleevec's not going to work. The other way is, before you give it, to go back to the primary tumor and sequence the c-KIT gene, looking for where the mutation that's activated the c-KIT is located. And when you do that, you'll find out that about 85% of GISTs have an activating c-KIT mutation. The other 15% overexpress c-KIT but have wild-type gene sequence. 50 to 60% of the c-KIT mutations in GISTs are in exon 11, and when you look at those patients tend to be Gleevec resistant. The patients who have mutations in exons 9, 10, and 12 tend to be Gleevec sensitive. I may have gotten that reversed. I was hoping it was on the slide. It's been a long night, and I haven't done one of these in a long time. It's reversed. Exon 11 are the Gleevec sensitive mutations, and 9, 10, 12 are the Gleevec resistant mutations. That's right. Absolutely, that's right. So what should we do? Take the tissue into the lab and sequence it and then predict response, hold back the drug because we can say it won't work, or give a dose and PET scan? What's more expensive? Definitely a dose plus a PET scan. What's better for the patient? I'm not sure. But it brings up this issue: is functional imaging complementary or competitive with in vivo laboratory molecular diagnostics testing? And despite everything you read in the literature and in public media that says these two are complementary, that will advance medicine, I say they are absolutely head-to-head, battle-to-the-death competitors. There's only so much money around, and we're only going to be able to do one or the other. So what's better? The tests you do before you give the drug, or the expensive test you do after you give the drug? And we'll see what happens. There are going to be more of these. At the AACR plenary session, I saw a study that shocked me. I was so impressed from MGH that looked for a variant expression of EGFR in glioblastoma called EGFR V3, variant 3. It's considered a marker of sensitivity to Tarceva, to erlotinib in glioblastoma. This study was done while the tumor was still in the patient by functional imaging. That they could set up the functional imaging to show that the glioblastoma was a variant 3 EGFR expressor. Didn't need a neurosurgeon to get him a piece of tissue and me in the lab to stain it for V3. So that immediately we said that the battle is getting more serious. We're going to have to decide what's best to do in the patient by functional imaging and what's best to do in the lab by molecular diagnostics. And it's going to be diseases like GIST where that story is going to play itself out.